the new long-term care survey process, and changes to the regulations. Presented by Jean Hesterly. The overview. Overview of regulation reform, FTAG renumbering, new interpretive guidance, current survey processes versus new survey process, the new long-term care survey process, long-term care surveyor training, state preparation, and questions. Overview of regulation reform. Overview of regulation reform. The regulation reform implements a number of pieces of legislation from the Affordable Care Act, or ACA, and the Improving Medicare Post-Acute Care Transformation, or IMPACT Act, including the following: Quality Assurance and Performance Improvement, QAPI, reporting suspicion of a crime, increased discharge planning requirements, and a staff training section. This is an implementation grid that shows the implementation date, the type of change, and details of the change. Phase 1 took effect in November of 2016 on the 28th. The type of change was a nursing home requirements for participation, and the details included new regulatory language uploaded into the automated survey processing environment, which is the federal database where inspections are recorded and distributed as statements of deficiencies. Implementation date for Phase 2 was November 28th of 2017. There was FTAG renumbering, interpretive guidance, and implementation of the new survey process. Details of the change. There were new FTAGs presented, updated interpretive guidance, and the new survey process was implemented. Phase 3 will be effective November 28th of 2019. The requirements that require more time for implementation will take place at this time. Requirements that need more time. A bit more about the Phase 2 of long-term care regulations. The implementation took place November 28th of 2017. Providers were expected to be in compliance with Phase 2 regulations. All states will use new computer-based survey processes for long-term care surveys, and all training on the new survey process needs to be completed before the go-live date of November 28th. Phase 2 of long-term care regulations continued. Behavioral health services, quality assurance and performance improvements, QAPI plan only, infection control and antibiotic stewardship, physical environment as it relates to smoking policies. Phase 2 of long-term care regulations continued. Residents' rights and facility responsibilities, required contact information, freedom from abuse, neglect, and exploitation, 1150B, admission, transfer, and discharge rights, transfer and discharge documentation. Long-term care regulations continued for Phase 2. Comprehensive person-centered care planning, pharmacy services, psychotropic medications, dental services, replacing dentures, administration, facility assessment. FTAG renumbering. The image above is the FTAG crosswalk showing the original regulatory grouping and the new associated grouping, the original regulation number and the new associated regulation number, the original F tag and the associated new F tag. As you can see, there's a change in the numbering system, and there will be additions as well to the F tags. This is a larger view of the crosswalk. The crosswalk is currently available online, and it's a job aid that was available as of fall of 2017. Now let's switch topics and discuss the survey process, the old survey process versus the new survey process. Why is CMS changing the long-term care survey process? There were two different survey processes being used to review for the requirements of participation, the traditional method and the QIS method. Surveyors identified opportunities to improve the efficiency and effectiveness of both survey processes. The two survey processes appeared to identify slightly different quality of care, quality of life issues. CMS set out to build on the best of both, the traditional and the QIS processes, to establish a single nationwide survey process. The QIS process was a computer-based process that was not being utilized in Nevada. The new long-term care process replaced both the traditional and the QIS processes, which meant that everyone in the country would be using the same process. When designing the new long-term care survey process, they took into account the strengths from both the traditional and the QIS. They are using new innovative approaches. It's meant to be more effective and efficient. It's resident-centered. And there's a balance between structure and the surveyor's autonomy. Automation. In the traditional survey process, the survey team collects data and records the findings on paper. The computer is only used to prepare the deficiencies recorded on the CMS 2567, better known as the Statement of Deficiencies. With the Quality Indicator Survey, or QIS, each survey team member uses a tablet PC throughout the survey process to record findings that are synthesized and organized by the QIS software. With the new survey process, each survey team member uses a tablet or laptop PC throughout the survey process to record findings that are synthesized and organized by new software. The sample size for the new survey process will be based on the facility census. The sampling approach for the new survey process is different than either current processes. The sample of the new survey process includes 70% of MDS pre-selected residents and 30% surveyor-selected residents. In the traditional survey process, sample size was determined by the facility census. The residents were pre-selected based on QMQI percentiles. Sample may be adjusted based on issues identified on tour. The maximum sample size was 30 residents, and it included complaints. With the QIS survey process, the ASEQ provides a randomly selected sample of residents for the following. Admission sample is a review of up to 30 current or discharged resident records. Census sample includes up to 40 current residents for observation, interview, and record review. With QIS 4.04, complaints were able to be included in the census sample. With the new survey process, sample size is determined by the facility census. 70% of the total sample is MDS pre-selected residents and 30% of the total sample is surveyor selected residents. Surveyors finalize the sample based on observations, interviews, and a limited record review. The maximum sample size is 35 residents. All of the survey processes review facility history information to prepare for the survey. In addition, surveyors would review the off-site selected residents and facility rates during off-site preparation, which is similar to the traditional process. In the traditional process, review of CASPER 3 and 4 reports was performed. Survey team used QM and QI's report off-site to identify preliminary sample of residents' areas of concern. With the QIS method, review of CASPER 3 report and current complaints, downloading of the MDS data to PCs, ASEQ selects a random sample of residents from stage 1 through residents with MDS assessments in the past 180 days. With the new survey process, each team member independently reviews the CASPER 3 report and other facility history information. Review off-site selected residents and their indicators and the facility's rates. Similar to the other processes, there will be information requests immediately upon entering the facility, which we'll discuss in detail later. With the traditional survey process, a roster sample matrix form was provided to be completed and given back to the survey team by the administrator. With the QIS survey method, they obtained census number and alphabetical resident census with room numbers and units, and a list of new admissions over the last 30 days. With the new survey process, completed matrix for the new admissions over the last 30 days is requested, the facility census number, an alphabetical list of residents, and list of residents who smoke and designated smoking times and places. Unlike the survey processes in the past, there is no formal tour for the new survey process. Surveyors will begin observing every resident in their assigned area to identify about 8 residents for the initial pool process, and then will spend about 8 hours completing the observations, interviews, and record reviews for the residents selected for the initial pool. In the traditional method, information was gathered about pre-selected residents and new concerns. Determine whether pre-selected residents are still appropriate, and it took 1 to 3 hours on average. Using the QIS method, there was no sample selection, initial overview of the facility, resident population, and staff-resident interactions. It took 30 to 45 minutes on average for initial overview. With the new survey process, there's no formal tour process. Surveyors complete a full observation, interview all interviewable residents, and complete a limited record review for initial pool residents, off-site selected residents, new admissions, vulnerable residents, identified concern that doesn't fall into one of the above subgroups, 8 hours on average for interview, observation, and screening. However, at the beginning of these processes, as in all things being learned, it may take a bit longer. The new survey process took into account the strengths of both the traditional and the QIS processes and tried to balance consistency with surveyor autonomy. For the new survey process, surveyors are completing thorough observations, interviews, and a limited record review for the residents selected during the initial pool process. In the traditional method, the resident sample was about 20% of the facility census for resident observation, interviews, and record reviews. In Phase 1, focused and comprehensive reviews based on QMQI report and issues identified from off-site information and facility tour. In Phase 2, focused record reviews. Facility and environmental tasks are completed during the survey. With the QIS process, Stage 1 was preliminary investigation of regulatory areas in the admission and census samples and mandatory facility tasks started. In Stage 2, completion of in-depth investigation of triggered care areas and/or facility tasks based on concerns identified during Stage 1. In the new survey process, the resident sample size is about 20% of facility census. Interview, observation, and limited record review care areas are provided for the initial pool process. Surveyors can ask the questions as they would like. Surveyors meet to discuss the selected sample, and they may have more concerns than can be added to the sample. They may need to prioritize concerns. Once the sample is selected, the remainder of the survey is spent conducting investigations for residents, facility tasks, and closed records. The new survey process includes a group interview with residents who are active members of the resident council. However, the questions asked during the group are different from both current processes. During the traditional process, there was a meeting with the resident group council, and it includes resident council minutes review to identify concerns. With the QIS survey process, there was an interview with the resident council president or representative, and it included resident council minutes review to identify concerns. With the new survey process, there is a resident council meeting with active members and includes resident council minutes review to identify concerns. Now let's discuss the new long-term care survey process overview. The new survey process. The process builds on the best of both survey processes. Process is computer software based, input from various stakeholders. Survey process and software are in testing and development, and there was validation that took place. The new survey process is computer-based with 3 parts: the initial pool process, sample selection, and the investigative process. I want to give a really high-level overview of the entire survey process before going into more detail. There are 3 main parts to the new long-term care survey process: the initial pool process, sample selection, and investigation. In the initial pool process, the sample size is based on the census, 70% off-site selected, 30% selected on-site by the team, with a focus on vulnerable, new admission, complaint, facility reported incidents for federal only, and identified concerns. At the end of the first day or the middle of the second day, the survey team will identify the sample, Once the sample is selected, the remainder of the survey is spent investigating all concerns requiring further investigation for the residents in the sample. Facility tasks and closed record investigations will also be conducted. Section 1. Offsite Prep. As part of the offsite preparation, each surveyor will review the residents' selected offsite and facility rates. The team coordinator completes offsite preparation, which includes a review of the CASPER 3 report to identify patterns of repeat deficiencies, results of the last standard survey, complaints since the last survey, including active complaints, facility reported incidences, variances and waivers, and necessary documents are printed. The team coordinator makes unit assignments using the floor plan and the mandatory facility tasks assignments. For the new long-term care survey process, the facility tasks are grouped into those tasks required to be investigated on every survey and those only investigated if a concern is identified on site. There are 9 mandatory facility tasks. Dining, infection control, skilled nursing facility, beneficiary protection, notification review, resident council meeting, kitchen, medication administration and storage, sufficient and competent nursing staff, QAA, and QAPI. No off-site preparation meeting takes place. Section 2, Facility Entrance. Now we'll shift and discuss what occurs when the team enters the facility. The team coordinator conducts a brief entrance conference with the administrator and then goes to their assigned unit. The surveyor assigned the kitchen conducts a brief visit to the kitchen and then goes to their assigned unit. Everyone else goes immediately to their assigned units. Part of the team coordinator's entrance conference includes an updated entrance conference worksheet, an updated facility matrix. CMS has revised the matrix to more effectively capture those pieces of information needed for the survey. Section 3, the initial pool process. Now we will talk about the initial pool process, which begins once you get your assigned area. The surveyor will request names of new admissions in the last 30 days, and they will identify in the initial pool about 8 residents. These could be off-site selected, vulnerable, new admissions, complaints or facility reported incidents, and identified concerns. Observations, interviews, and limited record reviews will be done for each resident. The survey team will screen every resident. There will be suggested questions, but not specific surveyor script. And it must cover all care areas, including rights, quality of life, quality of care, and they will investigate further issues or they will find no issues. For the full observation, the surveyors will probe lists in each care area, conduct rounds, complete formal observations, and investigate further if they identify issues during their interviews and observations, or there could be no issues. Resident representative or family interviews. These take place generally for non-interviewable residents. They will want to speak to someone who's familiar with the resident's care, and they will try to complete at least 3 during the initial pool process or early enough to follow up on concerns. They will choose from sampled residents if at all possible, and investigate further if they identify issues. There will be a limited record review. It will be conducted after interviews and observations are completed prior to the sample selection. All initial pool residents will be expected to have advanced directives and confirm specific information in the record that they may have identified during observation or interview. If interviews were not conducted, then certain care areas are reviewed in the record. There will be confirmation of insulin, anticoagulant, and antipsychotic with a diagnosis of Alzheimer's or dementia, and PASAR, or pre-admission screening and resident review. For limited record review, new admissions with a broad range of high-risk medications, extenuating circumstances, then interviews of staff, and investigate further, or no issues. In addition to observing and interviewing the residents, there will be a full meal observation with the first full meal after entrance. All dining rooms and room trays will be covered. There will be observation to adequately identify concerns. If feasible, the initial pool residents with weight loss will be observed. If concerns are identified, then another meal may be observed by the inspectors. There will be periodic team meetings, usually a brief meeting at the end of each day to discuss workload, coverage, concerns, and synchronize and share data. Section 4, Sample Selection. Sample selection. Prioritize using sampling considerations. Replace discharged residents selected off-site with those selected on-site. You can replace residents selected off-site with rationale. Harm, substandard quality of care if suspected. Immediate jeopardy if identified. Abuse concerns. Transmission-based precautions. All MDS indicator areas if not already included. Unnecessary medication review. The system selects 5 residents for full medication reviews. Based on observation, interview, record review, and MDS, a broad range of high-risk medications and adverse consequences, the residents may or may not be in the sample. Section 5. Investigation. Resident investigation, the general guidelines. Conducting investigations for all concerns that warrant further investigation for sampled residents. Continuous observations can be done if required. Interview representative. The family representative, the guardian, if appropriate, when concerns are identified. Again, during your investigations, the majority of the time is spent on the floor observing and interviewing the residents and staff. only using the record to corroborate what you are seeing and hearing. You will use critical elements or CE pathways to help guide the investigation. Section 6. Ongoing and other survey activities. The system will select the residents for the closed record reviews. For death reviews, the system will select a resident who was not on hospice and died in the last 90 days. For the hospitalization review, the system will select a resident who went to the hospital and has not returned in the last 90 days. For community discharge, the system will select a resident who was discharged back to the community in the last 90 days. Appendix PP and critical element pathways will be used during the investigative process. Let's move on to facility tasks. These will be completed anytime during the investigative portion of the survey so they don't interfere with the initial pool observation or interview. There are pathways for every facility task which will be used to help guide the investigation. If concerns were identified during the first meal observation, there may be a subsequent meal observation. Appendix PP and the critical element pathways for dining will be utilized. The dining task is completed outside any resident-specific investigation into nutrition and/or weight loss. Throughout the survey, all team members are observing for breaks in infection control. A complete review of 5 residents for influenza and pneumococcal vaccinations will be conducted. Assigned surveyor reviews infection prevention and control and antibiotic stewardship program. A new pathway was developed for the beneficiary notices review to make the process more user-friendly. A list of residents who went home and were in the facility are chosen by the software. The facility completes a new worksheet on each of those 3 residents, and then the worksheet and the notices are reviewed by the survey team. An initial brief kitchen tour was conducted upon arrival at the facility, with observations focused on practices that might indicate potential for foodborne illness. Additional observations are made throughout the survey process in order to gather all information needed on food preparation, storage, and distribution to prevent foodborne illnesses to the residents. The surveyors will follow Appendix PP and the facility task pathway to complete kitchen investigations. There have been a few changes made to the medication administration task. If the opportunity presents itself, observation of medication for sampled residents whose medication regimen is being reviewed will be done. Otherwise, medications for any resident to whom the nurse is ready to administer meds is being observed. Included in the sampled residents, if the opportunity presents itself, to observe medication administration to these residents. Reconciliation of controlled substances will be observed during medication administration if it takes place. Observe different routes, units, and shifts. There must be at least 25 observation of medication opportunities. Medication storage requires observation of medication storage rooms and the carts. If there are issues, then the medication room and cart examinations are expanded. The Resident Council interview is a group interview with active members of the Resident Council. The interview should occur early enough in the survey to afford you enough time to investigate any concerns. The questions that are asked of the residents are different from the traditional or QIS. The interview is focused on specific areas. Such as abuse and sufficient staffing. In addition, you can ask the group about any identified concerns from the survey. A review of sufficient and competent nurse staffing will be conducted on every survey. This task requires to be investigated on every survey, since surveys are always considered whether staffing issues can be linked to resident complaints or quality of life and quality of care concerns. In addition, Phase 2 of the new rule puts a lot of emphasis not only on sufficient numbers of staff, but also the competence of staff. If concerns are identified with the environment, there'll be an investigation just on the relevant concerns that cause the task to be triggered. In an effort to increase efficiency wherever we can, we have identified areas that are duplicative with life safety code. For the new long-term care survey process, you will not have to investigate disaster or emergency preparedness. Section 7, Potential Citations. The final area to cover is potential citations. After individual compliance decisions are made, the team will make a compliance and scope and severity determination for all potential citations. The meeting takes about an hour on average, but could take longer. Once the team has made a compliance decision for every tag that came forward from each surveyor, then the exit conference will take place as always. Long-term care survey training. There's been a suspension of the traditional and QIS Basic Long-Term Care course from July through December of 2017. The new Basic Long-Term Care course will be conducted starting December of 2017. CMS has identified multiple layers of training that will be required to successfully implement the changes for Phase 2. CMS has a training plan that involves consistent staff with defined roles and responsibilities to aid in the consistency of the national implementation. The regional office and state agencies, IT and software training. There was an Aspen Coordinator's IT support training in August and September of 2017. Computer-based training modules became available to be utilized during training in September of 2017. CMS also provided for training with the providers and the public by way of national calls, Q&As, access to the surveyor training materials, videos on highlights of the interpretive guidance, and training tools, access to survey forms, and critical element pathways. Survey agency preparation. Implementation of the survey process on a national level in November of 2017 on the 28th was part of the Phase 2 process of the phase-in of the changes. New CMS-approved basic long-term care training materials were released and are being utilized by state agencies for training purposes. CMS will continue to have open communication with the Association of Health Facility Survey Agencies, or AFSFA, to promote successful implementation. Additional information can be found on the following websites: